Infectious disease can be caused by a variety of different organisms and pathogens. This includes bacteria, viruses, fungi, and parasites. A disease is said to be communicable when it's able to spread from person to person. There are several primary factors that contribute to a person's risk of infection. These include the type of organism, the dose of the organism, its virulence, mode of entry, the host's defense and resistant mechanisms. Depending on the type of the organism, it has different characteristics in how it can infect a person. Bacteria live, grow, and reproduce in the appropriate conditions outside the human body. When they're introduced to the human body, they can multiply within a host and cause infection. Viruses are smaller than bacteria and can multiply only when inside a host. Once they're exposed to the environment, they start to die. Fungi are similar to bacteria and are found in organic material such as feces. They are often the cause of opportunistic infections in immunocompromised patients. Parasites live in or on a host body and feed off of it. For infection to occur, the dose of an organism must be at a sufficient level to cause infection. An example of this is when a urine specimen is tested for the presence of bacteria. If it's greater than or equal to 100,000 colonies of bacteria per milliliter, then that's consistent with an active infection. Virulence is a pathogen's ability to invade and cause disease in a host. This includes the ability of the pathogen to survive outside its host. For an organism to cause infection, it has to enter through the correct mechanism. A virus that affects the respiratory system when inhaled doesn't cause infection if it's entered into the body through a scrape or a cut. Host resistance is your ability to fight infection. Generally, the healthier you are, the less susceptible you are to disease. Pathogens also have an incubation period, which is the amount of time it takes to cause disease. This incubation period can range from a period of days or even months, depending on the pathogen. Communicable diseases also have a communicable period, which is the period that they're able to transmit the disease to others. Your body has defense mechanisms, and this is how we protect ourselves from infection. The first one is our skin, which acts as a protective barrier to keep pathogens out. Your skin also has natural secretions that have antimicrobial properties in them. Your mucous membranes found in your urinary, respiratory, and GI tract work to trap pathogens and expel them from the body. A good example of this is goblet cells and cilia working together in your lungs to expel mucus and pathogens out of your body. Your immune system is also involved in this as it creates and releases antibodies that can target and fight a specific pathogen or organism within your body. Many of the pathogens and organisms that we're going to discuss today have a complication of a systemic infection. This is known as sepsis. This is your body's overreaction to the infectious process that can lead to shock, tissue, and organ failure. Sepsis requires prompt recognition, transport, and treatment by pre-hospital providers, as our goal is to begin treatment before the condition worsens into organ failure.
The Quick Sepsis Organ Failure Assessment, or QSOFA for short, is a screening tool that providers can use to rapidly identify patients at risk of mortality from a systemic infection. It assesses three different areas: a respiratory rate of greater than or equal to 22 breaths per minute, an altered mental status with a GCS of less than 15, a systolic blood pressure of less than or equal to 100 millimeters of mercury, and it assigns 1 point to each of these areas. A score equal to or greater than 2 is associated with poor outcomes from a systemic infection. QSOFA was originally used to assess for sepsis before laboratory testing was created, and it still has value in the pre-hospital setting to help us identify at-risk patients. The management for a patient with sepsis includes monitoring that patient's hemodynamics, maintaining airway and breathing, and being prepared to intervene when necessary, providing IV fluid resuscitation at a rate of 30 milliliters per kilogram in the first few hours, and utilizing vasopressors as needed for persistent hypotension. Prehospital providers are exposed to many different infectious organisms on a daily basis. In today's session, we will state and identify some of the common and emerging infectious diseases that providers may be exposed to.
Meningitis is a disease that's characterized by inflammation of the meninges. This is the covering of your brain and your spinal cord. There are two main types of meningitis to be aware of. There's bacterial and viral meningitis. Viral is non communicable and represents 90% of the cases we see in the United States. The second form is more severe and it is communicable, meaning that it can spread from person to person, and that's bacterial meningitis. There are several different types of bacteria that can cause meningitis, but the most severe is meningococcal meningitis, which is caused by the bacterium Neisseria meningitidis. The US has a mortality rate of 14.3% for bacterial meningitis, and transmission occurs through direct contact with a patient's oral and nasal secretions. Now, this can also occur if you're in direct contact with a patient for longer than 8 hours. So, currently, there is a meningitis vaccine that is recommended for those that live in close quarters, such as college students in dorm rooms, middle and high school students, and military members. As providers, we're most at risk for an exposure to bacterial meningitis during airway procedures such as intubation and nebulized medications. So, wearing the appropriate PPE is important in these situations. The classic presentation of meningitis includes a sudden onset of a fever, projectile vomiting. Most cases report an altered mental status. Patient may complain of a stiff neck, and in 10 to 20% of cases, the patient may report some sort of nerve abnormalities. And there are two signs to be aware of with meningitis. The first one is Kernig's sign. This is when the patient is unable to extend at the knee when their hip is flexed. And Brzezinski's sign is when you have involuntary flexion of the knee when the neck is flexed. All of these symptoms should make you concerned of the presence of a meningeal irritation, such as meningitis. Meningitis is diagnosed via a lumbar puncture. When the cerebral spinal fluid is tested, we're looking for a bacteria to be present. If there is a bacteria present, then that is a confirmed case of bacterial meningitis, and providers who are involved in that patient's care will begin to be notified. And at that point, they may or may not need to receive post exposure treatment. The management of a patient with meningitis includes droplet precaution, PPE, for any provider involved in that patient's care. The patient may also be asked to wear a mask. The care of meningitis is primarily supportive. IV fluids as needed, treat the symptoms of meningitis. If seizures are present, utilize benzodiazepines, provide fluids on an as needed basis, and in some situations, advanced airway management may be needed. If you are exposed to bacterial meningitis via a confirmed case through lumbar puncture, then you may be offered post exposure antibiotics. There are cases of antibiotic resistant bacterial meningitis, so this is something that you will counsel with your doctor about to determine if you should receive these antibiotics. Influenza is a communicable disease that is most prevalent in the United States during the winter months. This disease primarily affects the respiratory system and is responsible for approximately 36,000 deaths in the US each year. There are a variety of different flu viruses. Types A and B affect humans. There are also animal influenzas. These are most concerning because at certain times they have shown to change their characteristics to infect humans, and this gives them a higher likelihood of causing a pandemic, such as with the avian flu. The flu virus is spread through respiratory droplets and on surfaces. So the flu is not an airborne virus, and it is contagious for 5 days after symptom onset. Receiving an influenza vaccination can prevent death from the flu. There are several different types of vaccines that are available for people who may be allergic to eggs or shellfish. There's also a vaccine available that does not contain a live virus. Patients who receive the vaccine typically, if they do contract flu, experience a milder case and are less likely to experience severe complications. As EMS providers, if we're experiencing cold and flu symptoms, we are extremely dangerous to people who have a higher risk of mortality from the flu. This includes immunocompromised children and elderly. Patients over the age of 65 are most likely to die from the flu. As healthcare workers, you may be required to receive the seasonal flu vaccine. In some instances, you may be able to sign a declination, and in that case, you might be asked to wear a mask when performing patient care. The symptoms seen with the flu infection are a result of your body's immune response to the virus. This includes fever, body aches, chills, and weakness. Respiratory symptoms that we may see include a cough, respiratory distress, nasal discharge, and in the most severe cases, the development of pneumonia. The management of the flu primarily involves prevention through vaccination, as this can prevent severe complications and death from the flu, and supportive care and management of sepsis in the most severe cases. Respiratory syncytial virus is the leading cause of a lower respiratory tract infection in children, older adults, and the immunocompromised. It initially presents as an upper respiratory tract infection before progressing into a lower respiratory tract infection, such as bronchiolitis. The mortality from RSV increases for patients who are less than 1 year of age, older than 65, and those with comorbidities such as diabetes, asthma, COPD, and heart disease. RSV is transmissible for 3 to 8 days and is spread through respiratory droplets. Fortunately, the US mortality rate is less than 1%, which equates to less than 400 deaths per year. The presentation of RSV as an upper respiratory tract infection includes coughing, sneezing, nasal congestion, and in some cases, fever and general weakness. As the virus progresses into the lower respiratory tract, you may see symptoms such as rhonchi and wheezing, hypoxia, and dyspnea. Severe complications of RSV include the development of pneumonia and respiratory failure. Our care for RSV is primarily supportive. We should don droplet precaution PPE and utilize good hand hygiene and decontamination practices before and after each cough. Pertussis, otherwise known as whooping cough, is caused by the bacterium Bordetella pertussis. This disease is characterized by coughing episodes followed by a whoop sound on inspiration. Other symptoms you may notice include a low-grade fever and nasal discharge. Pertussis is preventable through vaccination and is most commonly seen in children under the age of 5. Cases in the United States are increasing, largely as a result of unvaccinated children and diminishing immunity among adults. As a result, the CDC recommends that healthcare workers receive a Tdap booster every 10 years to prevent the rise in pertussis cases.
Oh, it's okay. It's okay. No, it's okay. Yeah, yeah. It's okay. Yeah. It's okay, sweetie.
Pertussis can be tricky, mainly because it presents extremely similar to a common cold, which we generally attribute to viral illness. In the case of pertussis, the first phase of symptoms is known as the catarrhal phase. This phase can last for up to 2 weeks and is characterized by a runny nose and cold symptoms that don't go away. As the first phase progresses, it moves into the paroxysmal phase, which is marked by coughing episodes and the whoop sound when the patient is finally able to take a breath in between coughing fits. This phase represents the movement of the bacteria from the nasal passages lower into the respiratory system, where it can lead to pneumonia. What's even more concerning with pertussis is that we know that it lives in the nasal passages of adults, and some adults may show no symptoms or very little symptoms at all. As a result, we can easily transmit pertussis to children and infants. Up to 65% of infants younger than 6 months old require hospitalization, and the mortality rate can be as high as 3% in some countries.
Tetanus is a bacteria that's caused by the bacterium Clostridium tetani. This can be found in soil, dust, and animal feces. Tetanus bacteria is found worldwide, and cases in the U.S. primarily occur in the unvaccinated population. Other patients at risk of contracting tetanus include elderly patients with diminishing immunity and IV drug users, as tetanus can be found on contaminated needles. There is neonatal tetanus that occurs when babies are born to an infected mother or through a contaminated medical instrument used when cutting the umbilical cord. The presentation of neonatal tetanus includes muscle rigidity, irritability, poor feeding, grimacing, and spastic contractions to touch. A baby with neonatal tetanus carries a poor prognosis. The classic presentation of tetanus is lockjaw or trismus. This is the most common symptom. Other symptoms you may find include muscle spasms with pain, drooling, urination, and defecation. A full recovery from tetanus can take months, and management of a patient who has tetanus is mainly supportive care, maintaining airway and respiratory status, utilizing benzodiazepines to relieve severe muscle spasms. Obtaining a patient history is also important. We can ask questions about the patient's vaccination status and any recent events where they may have been exposed to the bacteria, such as stepping on a rusty nail or cutting their hand on something at a horse barn. Lastly, there's no natural immunity from tetanus, and providers should educate the public on the importance of being vaccinated in addition to providers being vaccinated themselves. The diphtheria bacteria leads to an exotoxin within your body, and this is what makes you sick. Vaccination programs have been able to drastically reduce the number of cases, and cases in the U.S. are mainly seen in low socioeconomic status groups with poor access to health care who are also not vaccinated. The U.S. sees about 1,000 cases per year, and diphtheria is primarily a disease of childhood where it affects children under the age of 12. Overall, diphtheria has a 5 to 10% mortality rate, and in patients who do not receive treatment, that can rise to as high as 50%. The incubation period for diphtheria is 2 to 5 days. This exotoxin primarily affects your respiratory system and results in flu like symptoms such as a fever, sore throat, and swollen lymph nodes. A characteristic finding of diphtheria is a pseudomembrane that develops as the toxin kills healthy tissue and forms a membrane over top. This membrane consists of red blood cells, white blood cells, and dead tissue. Most commonly occurs over the tonsils and in the back of the throat. Diphtheria can become a serious illness if it's able to progress to systemic involvement. This can occur as the toxin leaks into the body through the lymph and circulatory systems. A severe complication from diphtheria would include kidney failure, myocarditis, and airway occlusion as the pseudomembrane can inhibit ventilation. The toxin can also affect the skin by forming a pseudomembrane over certain areas of the skin. This form of diphtheria rarely results in a severe disease. The management for a patient infected with diphtheria. Primarily, this includes vaccination of providers, public education regarding vaccination schedules. The Tdap vaccine is given to adults and is recommended every 10 years. Children receive a different vaccine that still contains tetanus, diphtheria, and pertussis, and they receive this vaccine at 2, 4, 6 months of age, again at 15 to 18 months of age, and then once more between 4 and 6 years old. They will not receive another booster until they're age 11 before receiving the vaccine like adults would every 10 years. Considerations when caring for a patient who has diphtheria. When obtaining a medical history, inquire about vaccination status and any recent travel from countries that may be in a current endemic for diphtheria. Utilize contact and droplet precautions as diphtheria is spread through coughing and sneezing. Manage the patient's symptoms to airway and breathing. Depending on the size of the pseudomembrane, this can impair ventilations, so be prepared to perform advanced airway management. Hospital treatment involves administering an antitoxin to help neutralize the toxin in the blood and help prevent a severe complication, and an antibiotic that's given as soon as possible to help limit the amount of toxin that's released into the blood.
Mumps is a contagious viral illness, and prior to a vaccine that was created in 1967, there was 186,000 cases of mumps reported each year. Despite having a vaccine, mumps is showing a resurgence in the US as there was 3,780 cases reported in 2019. And there have been outbreaks of mumps in college dorms and most notably in 2015 in the NHL. As a result of this, in 2018, the CDC recommends a third dose of the mumps vaccine for those students who are at a higher risk of outbreaks, such as college students. Mumps is transmissible through a patient's respiratory droplets and can also live on surfaces. The presentation of mumps includes fever, general weakness, and a headache. In over 70% of cases, patients report swollen parotid and salivary glands. Severe complications from mumps include permanent deafness, meningitis, Guillain-Barré after the infection, and hydrocephalus. Fortunately, most cases of mumps are not life-threatening. The management for a patient with mumps includes PPE for providers. We should don contact and droplet precaution PPE as mumps can survive on surfaces such as clothing. The care for a patient with mumps is primarily supportive and managing the patient's symptoms, providing transport if necessary. Rubella is a viral disease that is no longer endemic in the United States and was thought to be eradicated in the US in 2004. Cases are still seen in the US as a result of travel from other countries. The way rubella is spread is through a patient's respiratory droplets when they cough or sneeze. Patients are contagious from rubella up to 7 days after symptoms appear, and in 25 to 50% of cases, patients show no signs or symptoms. As a result of this, vaccination is a critical component to preventing rubella from spreading throughout the nation. The disease is generally mild, and in most patients presents as a rash that starts on the face and then spreads to the rest of the body. Other symptoms you may note include a runny nose and swollen lymph nodes. The major reason why vaccination against rubella is so important is because how devastating it can be to a pregnant female and her unborn baby. The last outbreak of rubella in the United States occurred during 1964 and 1965. During this time, there was over 12 million people affected with rubella, 11,000 pregnant females, 2,000 infant deaths. Congenital rubella syndrome occurs when a pregnant female contracts the disease. This can lead to miscarriage and multiple different types of birth defects, causing lifelong morbidity. It is most dangerous for mothers during the first trimester of pregnancy. In 2015 to 2018, there was only 15 cases of congenital rubella syndrome. Cases are seemingly increasing as a result of decreased vaccination rates among children. Tuberculosis is a disease that primarily affects a patient's respiratory system and is caused by the Mycobacterium tuberculosis. In 2019, the lowest number of cases in the United States were reported of 8,916 cases. Throughout the majority of the world, TB is still a major concern. There are three different types of TB: typical TB, which is communicable, atypical, and extrapulmonary. These types of TB are not communicable diseases and occur in the bone, kidney, and lymph nodes. Two types of TB infection with typical TB occur. Latent TB is someone who has tested positive for the bacterium but does not have an active infection. Active TB, this person has tested positive and is actively showing symptoms and is confirmed via a chest x ray and lab work. This form of TB is communicable. There is also antibiotic resistant forms of TB that have been identified, such as multi drug resistant TB and extra drug resistant TB, or XDR TB for short. Tuberculosis is spread through airborne particles from someone who has an active infection. Those at highest risk of contracting tuberculosis are people who are incarcerated or live in prolonged contact with someone who has an active TB infection. In the United States, the Asian population has the highest incidence of tuberculosis infection. As paramedics and EMTs, we're at the highest risk of infection during airway procedures on a patient who has an active infection. Infection of TB can be found early with TB testing. There's a blood test that is available that is reliable and fast. A TB skin test can take 48 hours to be completed and needs to be read by a qualified provider, such as a paramedic. The general recommendation from the CDC is that at the time of employment for a healthcare worker, a TB skin test or blood test is completed, and some agencies may require this yearly. Tuberculosis is considered in patients that have a persistent cough for more than 3 weeks and one of the following symptoms: headache, fever, fatigue, unexplained weight loss, coughing up of blood, hoarseness, and chest pain. When managing a patient with known or suspected TB infection, we can ask our patients to wear a mask if they're able to contain their respiratory droplets. As providers, we should wear airborne precautions with an N95 mask. If needing to administer oxygen to the patient, consider a non-rebreather over a nasal cannula, as a non-rebreather can also help contain respiratory droplets. If you're exposed to tuberculosis and you are not wearing PPE, notify your infection control officer and follow your local protocols. Those protocols may include obtaining a baseline TB test and then 8 to 10 weeks later, obtaining another TB test to assess for the presence of tuberculosis. At that point, if positive, you may receive a chest x ray and a 12-week round of antibiotics. Varicella zoster virus, otherwise known as chickenpox, is a highly contagious viral illness that is spread through direct contact with an infected person's skin lesions or inhalation of respiratory droplets. The varicella virus is a member of the herpes family, and once infected, it can reactivate later in life and present as shingles. A vaccine became available in 1995 and is effective at preventing against severe disease. The presentation of chickenpox includes a distinctive rash and skin lesions throughout the patient's body that typically begin in the abdominal area. Other symptoms to consider include a fever and photosensitivity, where a patient wants to remain in the dark. There is no specific management for a patient with chickenpox. Providers should wear airborne PPE precautions. If you are exposed without PPE and you are not vaccinated against chickenpox, you may be offered the vaccine within 72 hours. Measles is a highly contagious viral illness that primarily affects children. This disease is spread through respiratory droplets that can remain airborne for up to 2 hours, in addition to measles being able to live on surfaces. Patients who have this virus are contagious 4 days before a rash appears and up to 4 days after the rash appears. Prior to a vaccination in 1963, over 500,000 cases were reported, with approximately 500 deaths per year from measles. The initial presentation of a patient with measles begins with a fever, conjunctivitis, rhinitis, and this is followed by coughing and the development of its distinctive rash. You may also see what's called copelet spots, which are white-gray spots that form around the mouth. When managing a patient with measles, treat the patient's fever and keep them comfortable. Place PPE on the patient, such as a mask or a gown if they're able to accept it. For providers, wear airborne and contact precautions. Utilize your ambulance's exhaust fan and open windows if you're able to. Providers should also be vaccinated as a way to protect against transmission of the virus.
Severe acute respiratory syndrome, or SARS for short, became the first pandemic of the 21st century. In 2003, an outbreak of SARS spread across 30 countries saw 8,056 cases, 774 deaths, and a 9.6% fatality rate. The SARS outbreak in 2003 really showed us how an infectious microbe can very easily and quickly spread throughout our society as a result of international travel. In 2003, SARS was a novel coronavirus and was thought to have changed characteristics from being able to infect animals to infect humans. It also seems that diseases are jumping more often from animals to humans, such as monkeypox, avian flu, SARS, COVID 19. The cases in the US were limited, as the US during this outbreak saw 8 cases and no deaths. And the last reported case of SARS came from China in 2004 and was thought to be a result of a laboratory accident. During the last outbreak of SARS in 2003, the cases in the US were likely attributed to travel from high infection areas. The presentation of this virus initially begins with a dry cough, fever, fatigue, and can be followed by more severe symptoms such as dyspnea and respiratory failure. Deaths are attributed to the SARS virus via acute respiratory distress syndrome, secondary infections, and septic shock. An interesting statistic with the SARS outbreak in 2003 is that 21% of cases occurred in healthcare workers. This highlights the importance of wearing proper PPE and utilizing good hand hygiene and decontamination practices to prevent infecting ourselves. If you're caring for a patient who has severe acute respiratory syndrome, you should utilize airborne and contact precautions.
As of April 2023, 104 million cases of COVID 19 have been reported, with 1.1 million deaths. COVID 19 is believed to have originated from China in 2019 and became pandemic in the United States in 2020. Recent testing has shown that COVID 19 may have been present in the United States prior to December of 2019. Transmission occurs through respiratory droplets and contact with a contaminated surface. However, surface contact is not COVID 19's primary method of transmission. As providers, we are at greatest risk of exposure during airway procedures, such as ventilations, intubation, and nebulized medications. Wearing proper PPE and utilizing your ambulance's exhaust fan, in addition to thorough decontamination after a call, can help mitigate the risk of contracting COVID 19. The presentation of COVID 19 includes patients experiencing fever, cough, dyspnea, in some cases, loss of taste or smell, muscle aches, sore throat, and chills. Severe complications of COVID 19 include hypoxia, respiratory failure, exacerbation of comorbidities, and in some cases, pneumonia. A dispatch screening may advise the patient to wear a mask, and in some cases, ask that person to come to the front door to prevent providers from being exposed as we enter the residence. When managing a patient with COVID 19, providers should wear the appropriate level of PPE. This should include an N95, eyewear, gloves, and some protocols require a gown. Maintain the patient's airway, breathing, and circulation. Give IV fluids as needed for dehydration. Treat the patient's fever and manage any complications that may be occurring as a result of the virus. Utilize airway procedures only as necessary, such as nebulized medications and more advanced procedures like intubation. After the call, decontaminate your ambulance thoroughly. This may include a more robust cleaning schedule utilizing an electrostatic sprayer, a fogger, or UV light. Scabies is caused by a parasite and is spread through direct skin to skin contact. Patients most susceptible to scabies include families, chronically ill, sexual partners, and patients who live in group homes or close settings. Cases in the US are increasing with scabies, and the communicable period lasts until all of the mites and eggs have been destroyed. Scabies presents as small red bumps in common areas throughout your body, such as your hands, in between your fingers, your feet and ankles, and in some cases, the abdomen and buttocks. The small red bumps are extremely itchy and patients may itch them until they become open sores. When caring for a patient with scabies, utilize standard precautions. You may also choose to wear a gown. It can also be good practice to keep the patient covered so that their skin is not exposed to any other providers. After the run, be sure to change any linens that the patient may have used or came into contact with and clean the ambulance thoroughly.
Scabies, or human itch mites, are found worldwide and affect all races and socioeconomic classes. Symptoms from someone's first infection can take 2 to 6 weeks to appear. Patients with scabies can spread the parasites before symptoms appear, and animals are not responsible for spreading the disease.
Ebola is a lethal virus that causes viral hemorrhagic fever. The mortality rate from Ebola can be as high as 50% and is largely dependent on the strain of Ebola contracted and that person's access to healthcare. There is an Ebola vaccine that is 100% effective, and Ebola has been contained to African countries, with the last major outbreak occurring in 2020. Transmission of Ebola occurs through direct contact with a patient's blood, body fluids, or contaminated surfaces. The presentation of Ebola includes a fever, vomiting, diarrhea, a headache, and muscle aches and pains. Some patients may also experience internal and external hemorrhage. Screening for patients traveling from outbreak countries can help you correlate the signs and symptoms with the disease of Ebola. When managing a patient with suspected or known Ebola or viral hemorrhagic fever, you should limit and document the number of providers involved in that patient's care. We should also don the appropriate level of PPE. This includes a full sleeve gown, 2 pairs of gloves, an N95 mask or a PAPR, a full face hood, and boot covers. Consider PPE for the patient also, a mask and a gown. The more body fluids that the patient has, such as diarrhea, urine, vomiting, the more transmissible the disease is. Also, we should utilize invasive procedures, such as an IV, to only as necessary. Provide the hospital with an early notification so they can prepare. And lastly, clean your unit thoroughly after the call. Norovirus, otherwise called the stomach bug, is a common cause of gastroenteritis and responsible for approximately 21 million cases of GI illness each year. Elderly and immunocompromised patients have the greatest risk of mortality from norovirus at 7%. Symptoms begin after 24 to 48 hours and can last for up to 3 days. Norovirus is spread through the fecal oral route and contact with a contaminated surface. It presents as diarrhea, abdominal pain, nausea, vomiting, and in some cases, a low grade fever. Healthcare outbreaks of norovirus are common. Utilizing standard precautions and good hygiene are noted as the best ways to prevent the spread of norovirus. Also, when cleaning surfaces, utilize a bleach based solution as this kills the norovirus.
The Kaplan criteria can assist providers in identifying neurovirus. In over half of cases, vomiting occurs. The mean incubation period of norovirus is 24 to 48 hours, with a mean duration of illness of 12 to 60 hours. And the last section of the Kaplan criteria is no bacterial pathogen identified on stool cultures.
Hepatitis is viral inflammation of the liver. There are multiple different variants of hepatitis, such as hepatitis A, B, and C. Hepatitis A and E are not bloodborne inflammation of the liver. The presentation for each form of hepatitis is similar. It includes fatigue, fever, muscle aches or aching in your joints, the loss of appetite, nausea and vomiting initially. Smokers may lose interest in smoking, and symptoms consistent with acute or chronic liver failure include jaundice, dark colored urine, pale gray stools, and yellowing of the eyes. Hepatitis A and E are spread via fecal oral route. or contaminated drinking water. As providers, we should wear gloves anytime we're in contact with a patient, especially if that patient has exposed fecal matter. Hepatitis A. When you acquire hepatitis A, it produces a lifelong immunity and very rarely presents as a lifelong infection or inflammation of the liver. Hepatitis E is common in underdeveloped countries, and cases in the US are usually due to someone who travels from an endemic country. Hepatitis B is transmitted through blood, semen, and other body fluids. It's prevalent among IV drug users who share needles. It can live on surfaces for up to 7 days, such as the bench seat in an ambulance. The average onset of symptoms is 90 days, with most patients able to recover over a period of weeks or months. 20 to 30% of patients may develop chronic liver failure or cancer, and there's currently no cure for hepatitis B. As providers, we should utilize standard precautions and be vaccinated against hepatitis B. If we are exposed to hepatitis B and not vaccinated, you may be offered hepatitis B immunoglobulin and then offered the vaccine. Hepatitis C is spread through the blood of an infected person. This can occur in healthcare via a dirty needle stick. Hepatitis C can live on surfaces for a prolonged period of time, up to 16 hours. Patients may get acute or chronic liver failure. Acute liver failure as a result of hepatitis C occurs within 6 months, and 75 to 85% of patients develop chronic liver failure as a result of hepatitis C. There is an 8 to 12 week treatment program that can cure hepatitis C if a healthcare provider is exposed. HIV is a virus that attacks a patient's immune system and prevents it from responding to other diseases. AIDS, or acquired immunodeficiency syndrome, is the end stage disease of HIV and is characterized by a decreased amount of helper T cells, which help regulate your immunity. This exposes a patient to opportunistic infections. HIV is transmitted through blood, semen, vaginal fluid, and breast milk. It can also be transmitted during a blood transfusion, as blood is tested for HIV, but it is not 100% accurate. The CDC reports that in 2021 there was 36,000 new cases of HIV. 7% of those occurred as a result of drug use. Healthcare workers acquiring HIV is extremely rare. Since we've known about HIV, there have only been 58 confirmed cases of a healthcare associated HIV infection. Only one of those was the result of a dirty needle stick, and none of the 58 confirmed cases occurred in fire or EMS. Recent advancements in HIV care are able to reduce the viral load of HIV to undetectable amounts. This can render the virus unable to multiply. This also prevents transmission of the disease from person to person. The Ryan White Care Act of 1990 mandates that any patient with HIV can receive care in the United States regardless of their ability to pay. The presentation of HIV begins with an acute febrile illness, malaise, and some cases swollen lymph nodes. After this initial infection, most patients have swollen lymph nodes but otherwise appear healthy. If left untreated, HIV progresses to AIDS by lowering the amount of helper T cells, which decreases the patient's immune response and exposes them to opportunistic infections. When managing a patient with HIV, as providers, we should utilize standard precautions and safe needle practices. This includes immediately discarding sharps into the appropriate container after they are used. If an exposure does occur, follow your local protocols and notify your infection control officer. You may receive a rapid fingerstick test that can determine the viral load of HIV, and depending on the viral load, antiretroviral medications may be offered. This is not always needed, and you should follow local protocol direction. Staphylococcus aureus is a common bacteria that is found in human skin and nasal mucosa. The CDC reports that approximately 33% of people have this bacteria with no symptoms. MRSA is antibiotic resistant. and represents a significant issue in healthcare, as it can be spread from provider to patient through unwashed hands. MRSA can live on surfaces for weeks and enter through an open cut or wound in a patient's skin. MRSA presents as a localized soft tissue infection and cellulitis that can progress to serious complications such as sepsis, a bloodstream infection, and endocarditis. Provider considerations: utilize standard precautions. The management of MRSA often involves draining an incision of the localized soft tissue infection, so avoid contact with any of that fluid. If you're not wearing the appropriate PPE and you do have an entry port for the bacteria, such as a cut or a scrape on your hand, notify your infection control officer. Ways to prevent the spread of MRSA include keeping your hands clean and covering any open wounds on your hands or throughout your body. You should also clean commonly touched and high contact areas, not only in your ambulance, but also in your station. Clostridium difficile, or C. diff for short, is an infection that results from antibiotic use. Some antibiotics kill the normal bacteria within your intestines and can allow C. diff to take over. The CDC reports 500,000 cases each year and 29,000 deaths in the United States attributed to C. diff. C. diff is also a healthcare acquired infection and is spread through the hands of unwashed providers and contaminated services. You can also obtain C. diff in a community setting, most commonly via the overprescription of antibiotics. C. diff can also be found in the soil, animal, and human feces, and that can be a means of transmission in the community setting. Patients most at risk for the contraction of C. diff, aside from antibiotic use, include advanced age, chemotherapy, chronic renal failure, and patients taking proton pump inhibitors, which is a class of medication used to treat patients with acid reflux. The presentation of C. diff causes frequent watery diarrhea, nausea, vomiting, fever, and a loss of appetite. C. diff is considered as a diagnosis when a patient has 3 or more loose stools within a 24-hour time span. And severe complications of C. diff include sepsis, hypovolemia, and in some cases a toxic megacolon, which is where the colon becomes inflamed and can stop working. The pre-hospital management for a patient with C. diff includes supportive care, management of airway, breathing, and circulation, IV fluids as needed, and standard precautions and good hand hygiene for providers. If you suspect C. diff, utilize soap and water to clean your hands and utilize the appropriate cleaning solution to decontaminate the ambulance. This should be a bleach-based solution, as alcohol-based solution may not be effective at killing the C. diff spores. Vancomycin-resistant enterococcus, or VRE for short. Enterococcus is a common bacteria that can be found in your GI system. There's over 450 different species that exist, and normally it's not harmful to the human body. However, it can cause infection when it is spread from patient to patient through the fecal oral route and is most commonly spread in healthcare settings through the hands of unwashed providers. Enterococcus can live on surfaces as long as 4 months and can survive on a provider's hands for as long as an hour. It's considered VRE as it becomes resistant to vancomycin. Vancomycin-resistant enterococcus is one of the top 3 pathogens responsible for a healthcare-associated infection in the United States and can be attributed to 20,000 to 85,000 cases each year, and is largely a result of unwashed providers' hands. Patients most at risk for developing an enterococcus infection include those that are ill, immunocompromised, have open wounds, or use catheters, such as a urinary, central, or peripheral venous access catheter. Complications of VRE most commonly include a urinary tract infection, endocarditis, abdominal and pelvic infections, peritonitis, and a common and life-threatening cause of bacteremia if the bacteria is able to enter through a central or peripheral venous access line. The management for a patient with VRE includes supportive care and management of the patient's symptoms, Standard precautions and good hand hygiene for providers, clean any visibly soiled and touched areas by the patient, and the antibiotic treatment will be targeted to the specific bacteria, as it is thought that cases of VRE in the US have increased as a result of the use of vancomycin in clinical settings.
Vector-borne infections, also referred to as zoonotic infections, are transmitted through a vector, such as mosquitoes or ticks. Common ones that pre-hospital providers should be aware of include West Nile virus, dengue fever, the Zika virus, and tick diseases include Lyme disease and Rocky Mountain spotted fever. The West Nile virus is present in the US and causes approximately 2,205 cases each year. The mosquito obtains the virus after feeding off birds who are infected and can transmit that to humans when it feeds off of a human. West Nile virus is not communicable from person to person, and most cases are mild, with 80% of patients reporting no symptoms or very minor symptoms. In a symptomatic case, the most common complaints include a headache, fatigue, fever, weakness, and a rash. Dengue fever is also a disease that is transmitted by mosquitoes. There's 4 types of dengue fever that exist, and when you become infected with one of the viruses, you're immune to it, but you're not immune to the other 3. Cases in the US are primarily a result of patients traveling from somewhere and becoming sick when they're in the United States. No occupational risk to providers as dengue fever is not communicable. The presentation typically starts with a high fever and 2 or more of the following symptoms: a severe headache, pain behind your eyes, muscle or bone pain, a rash, easily bruising, and bleeding from your nose or gums. The Zika virus is another vector-borne disease that is most commonly contracted through the bite from an infected mosquito. It first appeared in the United States in 2005, and most of those cases resulted from travel. In 2017, however, Florida did see a short outbreak where they saw over 200 cases of Zika. Unlike other vector-borne diseases like West Nile virus and dengue fever, Zika is communicable and can be spread in several different ways. Aside from an infected mosquito, Zika can spread from an infected mother to her fetus. This can lead to severe complications, such as microcephaly, difficulty swallowing, and learning disabilities. It can also be spread through sex and contact with blood and other body fluids. The Zika virus has also been associated with the development of Guillain-Barré syndrome after the infection. The majority of patients who have the Zika virus are asymptomatic, roughly 60 to 80%. In a symptomatic case, the symptoms include a rash, conjunctivitis, fever, and headache. The care for a patient with Zika is supportive, and as providers, we should utilize standard precautions and avoid direct contact with the patient's body fluids. Zika has emerged as a new mosquito-borne infection that currently has no cure. As providers, we should educate the public about travel to certain countries that may be endemic, such as South and Central America. Lyme disease is caused by the bacterium Borrelia burgdorferi. It's the most common tick-borne disease in the US and can be transmitted to humans when a deer tick injects the bacterium. Lyme disease most commonly occurs during the summer months in the northeast United States, and over 30,000 cases of Lyme disease are reported each year. Lyme disease is not communicable, meaning it is not transmitted from person to person, and does not represent an occupational exposure risk to providers unless you are working in an area that has a tick infestation. The presentation of Lyme disease occurs in 3 stages. The early localized stage, which is a round skin lesion that extends outward at the center. This is commonly referred to as a bullseye rash and occurs in up to 80% of cases. The lesion can also be warm to touch and blister. The second stage is an early disseminated stage. You may have secondary lesions that develop in addition to flu-like symptoms, and if left untreated, several complications can arise. These include neurological involvement with meningoencephalitis, cranial and nerve abnormalities, and cardiac complications such as pericarditis and myocarditis. Late manifestations of Lyme disease include the development of arthritis over a period of days to months, intermittent joint pain, memory impairment, depressed mood, and fatigue. Rickettsia rickettsii is the bacteria that causes Rocky Mountain spotted fever. The ticks in the United States that cause this disease include the American dog tick, the Rocky Mountain wood tick, and a brown dog tick. It's most common in the southeast and south central United States during the summer months. It can result in a severe and life threatening disease if not treated promptly within the first few days, and carries a 20 to 30% mortality rate. The incubation period for symptoms is 4 to 10 days after the tick bite. Rocky Mountain spotted fever infects the vascular linings throughout the body and can lead to disseminated inflammation, loss of barrier function, and vascular permeability. This presents with symptoms such as a fever, headache, nausea, vomiting, muscle pain, and some patients may experience a rash. Severe complications include altered mental status and cardiac collapse. The management for a patient with a tick-borne disease in the pre-hospital setting is primarily supportive. We should ask the patient about travel and any outdoor activities that can indicate a source of infection via a tick bite, and also have a high index of suspicion for any patient with flu-like symptoms during the summer months. If the patient does have Rocky Mountain spotted fever, then doxycycline is the first line treatment and is most effective at preventing against severe disease if it's given within the first 5 days of symptom onset. If you do have a tick, it is important to remove it in the correct way, and as providers, we can help educate the public on how to do so in a safe manner. What you see on the screen here is a wood tick, which doesn't transmit Lyme disease. And when a tick is infected, it doesn't necessarily have a head, it just sinks its teeth into your skin. So when removing it, you do need a pair of tweezers so that you can grab the body of the tick. Avoid trying to use your fingers or squishing the tick, as this can inject any bacteria it may have into your patient or yourself. Hold the tick with the tweezers and pull straight up in a slow, steady motion, so avoid twisting the tick's body or anything like that. Once the tick has been removed, inspect the tick. You may see or be able to see a little white speck. That's the tick's teeth that it sinks into you. If you see that, then you know you have the entire tick removed. The CDC reports that the best way to dispose of a tick is to put it in an alcohol based solution, place it in a sealed container, such as a plastic bag, or wrap it tightly in tape and throw it away or flush it down the toilet.
Monkeypox is a virus that belongs to the same family of viruses as the smallpox virus. This was first discovered in 1958 when a group of monkeys used for research became ill, which is where the name monkeypox comes from. The first human case was discovered in 1970. There's two types of monkeypox viruses. There's clade 1 that is more severe and carries a 10% mortality rate, and clade 2, which is rarely fatal with a 99% survival rate. The last outbreak of monkeypox occurred in 2022 to 2023, and during that time, there was 31,689 cases in the United States and 56 deaths. Fortunately, the strain of the most recent outbreak was a clade 2 virus. The monkeypox virus is spread through close contact with a patient's respiratory droplets, skin lesions, and body fluids. Sexual transmission is a contributing factor to the spread of monkeypox in the United States, and as a result, the CDC has recommended that gay, bisexual, transgender, and non binary individuals receive the vaccine in addition to those who may be immunocompromised with a disease or virus such as HIV. Vaccination can occur up to 4 days after an exposure and prevent the onset of symptoms. Anyone who is infected with monkeypox should quarantine themselves and keep their lesions covered. When assessing a patient you suspect has monkeypox, we should perform a patient history and include questions related to travel to endemic areas and especially care for animals in those affected areas. The initial presentation of monkeypox is very similar to the flu, with a fever, headache, and fatigue. Some patients may also have swollen lymph nodes, and this is a differentiating factor of monkeypox from smallpox. Over the next couple days after symptoms appear, the patient may experience mucosal lesions that develop into skin lesions in certain areas of the body, such as the face, hands, neck, and commonly the genital region. These lesions will go through phases of a raised bump to a pus filled stage before eventually crusting over and falling off. The management for a patient with monkeypox is supportive care and transport to the hospital. Keep the patient's lesions covered and contain any respiratory droplets. So, this may include placing PPE on the patient if they can accept it. The United States monkeypox response guidelines include screening patients for travel from endemic areas such as Central and West African countries, airborne and contact precautions for responders who use safe donning and doffing practices. So we should don our PPE before making patient contact and doff our PPE in the appropriate area before leaving the patient's room. Consider PPE for patients if they're able to accept it to help contain the virus that can be spread through their skin lesions or respiratory droplets. Limit the amount of personnel involved in that patient's care. So this may include separating the driver from patient care and closing off the driver compartment from the patient compartment if your ambulance has that capability. When cleaning surfaces and equipment after your call, be sure that you're using a disinfectant labeled to kill vaccinia. This is the family of viruses that monkeypox belongs to. If you are exposed, notify your local infection control officer and follow your local protocol. It is common that if you do have an exposure or a patient with monkeypox and you're wearing the appropriate PPE, your risk of infection is low and there may not be any post exposure protocol to be followed.